Hello and welcome to the Public Health Report's Meet the Author webinar. My name is Frederick Shaw and I am the editor of Public Health Reports, the official journal of the U.S. Surgeon General and the U.S. Public Health Service. The PHR Meet the Author webinar series is presented to stimulate discussion around current topics in public health, featured in the May-June 2016 supplemental issue of Public Health Reports. Today's webinar will discuss the strategies for hepatitis B and C testing and linkage to care. On behalf of U.S. Surgeon General Vice Admiral Vivek Murthy, I want to thank Dr. John W. Ward and Dr. Aaron Harris from the Division of Viral Hepatitis at the National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention at the Centers for Disease Control and Prevention for joining us today. This and all PHR webinars are archived on the PHR website for future viewing, and a question and answer session will follow today's presentations. If you are interested in seeking 1 credit for certification in public health, continuing education, practice instruction, you will be given a password at the conclusion of the webcast. And now it's my pleasure to introduce Dr. John W. Ward, Director at the Division of Viral Hepatitis. Let us begin our presentation.
Thank you, Fred. Good day, everyone. I, speaking for the Division of Viral Hepatitis at CDC, really appreciate the opportunity to participate in this webinar as a follow-up to our publication in the supplement that was referred to, where we outlined a variety of strategies to improve hepatitis C testing and hepatitis B testing. What I'd like to do today, along with my colleague, Dr. Aaron Harris, is to bring you up to speed about why testing for hepatitis C and hepatitis B are important, and what are some of the studies that reveal strategies that can help us do a better job of testing persons at risk for hepatitis C and hepatitis B, identifying those infected, and linking them to life-saving and life-enhancing interventions. What I'll do in my time is to focus on the hepatitis C testing, and then we'll be followed by Aaron to talk about hepatitis B. Next slide, please. Just to start off with the key takeaways, hepatitis C is a large public health problem. There are about 3.5 million persons living with hepatitis C in the country, and if untreated, a large proportion of those will die of HCV-related liver disease or other complications. Currently, the U.S. is experiencing increasing numbers of HCV-related deaths, as well as increases in numbers of new infections, and proven testing-based strategies can stop these trends, prevent transmission, increase the number of people tested and linked to care and cured of HCV infection. Next slide, please. We view the public health issues around hepatitis C as battling 2 epidemics. One, on the right, there's an epidemic of HCV morbidity and mortality as a consequence of high incidence of hepatitis C in earlier years before the virus was discovered in 1989. And given that about 7 out of every 10 people once infected remain infected for life, you have a cohort effect of a large body of people, large number of people, moving through time who are at risk for hepatitis C. And we've categorized this as the baby boomer generation, people born between 1945 and 1965. They have a 6-fold higher risk of hepatitis C than other adults, and the average age of mortality of hepatitis C is 59 years, several decades younger than the average life expectancy. Coupled with that, we have increases in HCV transmission, which has been most apparent over the last 4 years. We've had about a 2.5-fold increase. This is among people less than 30 years of age, about equally male, female, and in non-urban parts of the country. I'll provide a little more detail about that in a moment. Next slide, please. HCV is a blood-borne virus. It's spread through contact with contaminated blood. in earlier years of this health problem, before the virus was discovered in particular, a lot of transmission through unscreened blood transfusions and exposures in healthcare. Exposures in healthcare continue to be a mode of transmission, but a much less common one. And the most common mode of transmission is now injection drug use, with a variety of risk factors within that risk population. There are other modes of transmission, as I'll be mentioning. Mother-to-child transmission is one we're particularly concerned about. Sexual transmission can occur, particularly among men who have sex with men who are HIV infected, but much less common than for HIV or hepatitis B. Next slide, please. Because of this cohort effect and because of the progressive risk of liver disease, the longer you have the infection, people are becoming more ill with hepatitis C. That's translating to increased healthcare costs, as noted in the line graph on the left, and the rising mortality, as noted in the graph on the right. And indeed, of all the infectious diseases reported to CDC, when you summarize all of their deaths, the number of deaths from hepatitis C exceed that number. Next slide, please. CDC updated our testing guidelines in 2012, where we recommended a one-time test for all persons born between 1945 and 1965, recognizing this cohort effect and the concentration of morbidity and mortality within that subpopulation, and then couple that with our pre-existing risk-based strategies, such as screening people who inject drugs. The benefits of knowing your status and being linked to care have been improved tremendously by the licensure over the last several years of highly effective, very safe antiviral agents that can cure HCV in over 90% of persons who complete the 8 to 12-week course of treatment. And with that, you get clear, demonstrable benefits in the reduction of liver cancer risk and the reduction in liver-related mortality. And indeed, we feel like just implementing the birth cohort strategy alone, even modestly, we can avert over 300,000 deaths from HCV. Next slide, please. The testing for HCV is a two-step process. One step, the first step, is the ordering of an HCV antibody test to identify those who have been exposed. If that is positive, it's followed up by a PCR test to identify current infection, since about 30% will spontaneously clear. So it's very important to have that two-step process to complete the diagnosis of current HCV infection. Next slide, please. Now, between 2012 and 2014, we put together a series of demonstration projects thanks to some particular funding from Congress. And many of those studies are highlighted in the supplement in public health reports. And I summarize these in a overall way just to show the high proportion of persons born in these birth years who are found to be HCV positive. We were focusing these demonstration projects in sites where we thought prevalence would be high, such as among African Americans and persons of low socioeconomic status. Recognize the challenge in getting people completely tested to identify those who are RNA positive, and then the success in getting them referred to care and reaching that first appointment, which was the endpoint of the study. So you can show you can have some success, but there's variability within that within those efforts. Next slide, please. And we recognize that there's a variety of different barriers that bear on one's success in getting people tested, and through a cascade of what I now call the cure cascade, getting people tested into a care and then linked to a care system where they can have access to life-saving antiviral therapy. The bar graph shows you sort of the status quo of that, how only about 50% of people know their status, and then there's a progressive decrease in those who've been successfully linked to care, and then only a very small proportion treated and cured of their infection. And we know that the determinants of that success reflects various levels of provider knowledge, lack of clinical decision tools, and other interventions that make the testing, care, and treatment process as simple and easy as possible. Performance measures to help people understand how well they're doing. Patient navigation for these marginalized populations who are less familiar with the health system, as well as there's reimbursement issues such as the cost of treatment, which has been a barrier, which we can talk about in the discussion period, but fortunately those drug prices are coming down, and through negotiation and other means, the restrictions which have been an issue for some health systems are lessening, and then increasing access to these treatments. Next slide, please. So let me give you some examples of some of these demonstration projects and what we learned from them. This bar graph is a study from Philadelphia where they implemented HCV testing in clinics serving homeless populations, large African American populations, either with no insurance or with Medicaid insurance. Number one, you can see that the exposures to HCV was found to be high in this population, but they successfully tested those persons for evidence of RNA. About 2/3 of those were currently infected with HCV, and then they had a high degree of success in successfully linking those individuals to care and having that individual meet that first appointment. What they saw as critical success factors was provider education, public education to build trust within that community, negotiations to get favorable pricing for diagnostics, and clinical decision tools that prompted testing when that person entered that clinical setting. And obviously they targeted heavily health disparities by virtue of that seroprevalence found. So it is a reminder that even with modest investments you can have a profound impact in improving testing and linkage to care. Next slide, please. Second example was at Grady Hospital in downtown Atlanta, where they implemented a physician residency program training whereby all the residents were trained about hepatitis C and the importance of testing, and then made a primary care clinic a referral site for those patients found positive. Next slide, please. Again here, they found 7% of those individuals were found to have antibody positivity indicative of exposure. A high proportion of those were successfully tested for current infection, and then a high proportion were successfully linked to care when they were found to be RNA positive. So that physician training and then having a site to refer patients were critical success factors. Next slide, please. Thirdly, at the University of Alabama Birmingham Emergency Department, they made it a standard practice to screen all baby boomers for hepatitis C. And so when a person entering the ED for non-emergent care checked in, they were told that this was standard practice for them to receive a test. 92% of individuals accepted that offer for testing as a routine procedure, and then that blood draw was automatically done and entered in and tested. Next slide, please. Now, in this case, they surprisingly found a high proportion of persons with exposures to hepatitis C, much more than what they were expecting. They successfully tested almost all of those individuals for evidence of current infection. Again, it found about 2/3 to be RNA positive or currently infected. What was a challenge for this emergency department was that they weren't really equipped to link people to care, and that showed up here that they had to do something different. But what's important here was that they made testing a routine process, and then they found a problem that they didn't know existed previously, and now they're in the process of trying to find ways of strengthening those linkages to care while they continue this testing program. So the emergency department can be a very important source of HCV testing. Next slide, please. The second epidemic is one of transmission, and it's very much linked to this prescription drug abuse epidemic that's going on in many parts of the country, whereby people are beginning to abuse prescription opioids, and then relevant to what we're talking about today, they progress on to the injection of those medications or the injection of other drugs such as heroin, and then become at risk for hepatitis C and become infected. The national map shows you the states that are experiencing increases in HCV. As you can see, that's the majority of the country. The second map shows you where that incidence is growing the highest or is already the highest, and that tends to be in Appalachia, lower Midwest, and Mid-Atlantic regions, as well as parts of New England. And that we have temporarily associated those increases with increases in reports of injection drug use among people who are entering drug treatment in the states that are reporting the highest incidence. Next slide, please. So again, we have developed demonstration projects to improve testing of persons who inject drugs. Now, when these were going on, many of these sites were not necessarily the sites where incidence was rising, but overall here you can see that about 1 in 5 to 1 in 4 persons who inject drugs in these settings were being found to be have been exposed to HCV. The RNA testing was unacceptably low in many of these sites, and so a clear area for improvement, because you need to know people who are, whether they're currently infected or not, and then refer them appropriately to care and to treatment. Next slide, please. One clear lesson learned from this demonstration project that is highlighted in the issue of public health reports is the what's called reflex testing, whereby the same specimen that's used to test for antibody is held aside pending that result. And if that result is positive, then that same specimen is then used to test for PCR. And so, and rather than requiring that individual to come back for a second clinic visit. And as you can see, you get much better results than the proportion of people knowing their status of current infection and then progressing on to be linked to care and attending those appointments. Now, all of that could be improved, but one key area for improvement is that reflex testing, so that that testing for RNA is done on the same specimen. Next slide, please. One other key area of concern about this new epidemic is the increasing number of women of childbearing age who are hepatitis C infected. And that's showing up in an increasing number of pregnant women being reported with hepatitis C at the time of birth. It's recorded on the birth certificate of the child. So we've had about a 23% increase in nationally to about 1 in 300 births or to a mother with evidence of HCV infection reported. And in some states like Kentucky, highlighted here, that's up to 1 out of every 63 births. There's about a 5 to 15% risk of mother-to-child transmission, and it really poses some new issues for public health regarding what are the right testing and management issues for women of childbearing age and pregnant women and neonates who are exposed to HCV at the time of birth. Next slide, please. Some of the key resources I just wanted to itemize here. If you want to learn more about our testing recommendations, those are available in the MMWR. The Infectious Disease Society of America and AASLD have come together to develop treatment guidance, and that's available at the website shown there. And then there's a larger body of information at the website of our division, and for both hepatitis C and what Aaron will be talking about in a few moments. So I just wanted to make sure you had those available so you could explore and seek while you're seeking more information. Next slide, please. Now, taken together, we know that we can now cure 90% of people who are living with hepatitis C and at risk of morbidity and mortality and ongoing transmission. We also know, although I didn't have time to explore it, that through various interventions of safe injection practices as well as testing and treatment, we can prevent over 80% of transmissions now of hepatitis C. And so the public health focus is beginning to turn towards setting elimination goals for hepatitis C and for hepatitis B. And the National Academies of Sciences, formerly known as the Institute of Medicine, is now in the process of doing that for the United States. They've developed a phase 1 report setting forth that goals can be developed in a feasible way. That was published in May and is available for your viewing. And then they will have a complete report about what targets are best and how to reach them. And that will be coming out in the first quarter of 2017. Something to look forward to. Next slide, please. So in summary, we have a large public health problem of hepatitis C. We have public health interventions that can have a profound impact at a time of rising morbidity and mortality and transmission. Testing is a key component of that because it can link people to necessary preventive services as well as care and treatment at a time where we now have transformational new drugs that can cure hepatitis C in over 90% of cases. So I hope this information has been helpful, and I look forward to further discussion. And at this point, I'll turn it over to my colleague, Aaron. Aaron?
Okay, next slide, please. Okay, good afternoon, everyone. Thank you, Fred, Dr. Ward, and participants on this call for inviting me to share with you results from our recent public health initiative to increase hepatitis B testing and linking foreign-born people with chronic hepatitis B virus infection to care at 9 U.S. programs during 2012 through 2014. Next slide, please. I want to start out by highlighting some important key messages regarding hepatitis B testing and linkage to care. First, as Dr. Ward mentioned, hepatitis B elimination is feasible, and it's feasible through routine infant and childhood vaccination programs, as well as vaccination of at-risk adults. Also through routine testing of at-risk adults and through linkage to care and treatment of persons chronically infected. Second, the highest hepatitis B prevalence is seen among foreign-born persons. Third, hepatitis B testing and linkage to care is cost-effective, and effective strategies require interdisciplinary approaches and strong community partnerships. Next slide, please. There are about 850,000 persons living with chronic hepatitis B virus infection in the United States. Of these, 70% are foreign-born. There are about 54,000 imported chronic hepatitis B cases each year, and of all the persons infected with hepatitis B, 60% are unaware of their infection. Of people living with chronic hepatitis B, 15 to 40%, or about 1 in 4 persons, will develop life-threatening complications. These complications include liver cirrhosis, hepatocellular carcinoma, and liver failure. And complications can take decades to develop, and most people living with chronic infections have no symptoms at all. And this is why it's often referred to as the silent epidemic. Next slide, please. This slide shows risk groups for which hepatitis B testing is recommended by the USPSTF, the CDC, and AASLD. Hepatitis B testing among persons born in intermediate to high hepatitis B prevalent countries has been recommended by the CDC since 2008, by AASLD since 2009, and by USPSTF since 2014. Other risk groups with high hepatitis B prevalence that should also receive testing include U.S.-born persons not vaccinated as infants whose parents were born in regions with high prevalence, HIV-infected persons, injection drug users, men who have sex with men, household contacts or sexual partners of persons known to be infected with hepatitis B, and pregnant women. Next slide, please. There is evidence to support hepatitis B testing and linkage to care. Linkage to hepatitis B directed care can achieve a reduction in hepatitis B associated morbidity and mortality. Testing and linkage to care has been shown to be cost effective. Studies have estimated that the incremental cost effectiveness ratio, or ICER, is between $36,000 and $46,000 per quality adjusted life year gained. Typically, an ICER less than $50,000 is considered cost effective. There was another study that compared early identification and linkage to care of hepatitis B infected persons late in their disease. The ICER in this study was about $20,000 per quality gained at 10 years and improved to $5,000 per quality gained at 20 years when compared to a later strategy. Therefore, it's important to identify persons early and test at-risk adults for hepatitis B. Next slide, please. This graph presents an overview of the cascade of chronic hepatitis B virus infection care in the United States. Of the total number of chronic infections seen on the far left bar, only 60% are aware of their infection. 25% enter into care, and fewer than 15% of treatment-eligible persons are receiving antiviral treatment. Next slide, please. To address the gap in linkage to care, and because testing and linkage to care can save lives and prevent life-threatening complications of hepatitis B, we launched a public health initiative to increase community-based viral hepatitis B testing and linkage to care activities of persons born in countries with intermediate to high hepatitis B prevalence. Next slide, please. The methodology for this initiative is described here. The project period was from October 2012 through September 2014. 9 sites participated. Each site developed strategic partnerships and engaged stakeholders. They worked with healthcare centers to develop protocols for linkage to care and hepatitis B management. The sites partnered with community-based organizations to improve community outreach. This was largely through faith-based organizations, educational organizations, and cultural organizations. The community-based organizations trained patient navigators whom were instrumental in educating community members about hepatitis B and encouraging them to get tested. Furthermore, sites utilized patient navigators to engage hard-to-reach populations. In addition, partnerships were developed with local departments of health, which improved reporting to local and state surveillance. The initiative measured the success of each program based on the completion of the following required procedures for each participating person. Participants received hepatitis B surface antigen testing. There was systematic collection of demographic and risk factor information for participants. Each program reported linkage to care information, and metrics for linkage to care included the proportion that received results, received post-test counseling, were referred to medical care, and had a medical visit attendance. Next slide, please. Through this initiative, we tested 23,144 persons for hepatitis B surface antigen. The median age of participants was 47 years. 83% of participants were born in countries with intermediate to high hepatitis B prevalence. The countries of birth with the highest number of participants included 22% from China, 9% from Somalia, 8% from Myanmar, 8% from Vietnam, and 4% from the Philippines. Next slide, please. This slide illustrates the hepatitis B virus care cascade from the initiative. We identified 1,317, or 6% of all participants that tested positive for hepatitis B surface antigen. Of these participants who tested positive, 1,188 received testing results, 1,117 received post-test counseling, 1,098 were referred to medical care, and 606, or 46% of persons with chronic hepatitis B virus infection stated that they went to at least one medical visit. Next slide, please. This is a table showing demographic information and risk factor information in the first column, the number of hepatitis B surface antigen tests completed in the second column, the number of surface antigen positive persons in the third column, and the number attending a medical visit in the fourth column. While there were more female participants tested, significantly more males tested positive and were subsequently linked to care. There was a higher proportion of persons aged less than 65 years, and more of them were linked to care compared to those 65 years and older. Significantly more blacks and Asians tested positive compared to whites. More black participants were linked to care compared to whites. However, significantly fewer Asians were linked to care. Lastly, a higher proportion of foreign-born persons tested positive compared to participants with no identifiable risk factor. And more of the foreign-born persons were linked to care. Next slide, please. This is a map that shows the hepatitis B surface antigen prevalence by region of birth for participants in this initiative. The darker shaded regions indicates a higher prevalence. The lightest shaded regions indicates a lower prevalence. The highest prevalence was observed from participants whose country of origin was Africa, East Asia, and South Pacific. And this is where the majority of the worldwide burden of hepatitis B is. Next slide, please. This table summarizes the performance of each participating site in the initiative. The order of sites is based on the prevalence of surface antigen from highest in New York City to lowest in Portland, Oregon. The important thing to point out from this slide is that there was variation among sites in terms of the number of participants and progression along the hepatitis B virus care cascade. Most sites did a great job of referring surface antigen positive persons to care. In total, 83% of surface antigen positive persons were referred to medical care, and Columbus, Ohio referred 100% of surface antigen positive persons. However, the referrals did not necessarily result in successful linkage to care, as 46% reported attendance of at least one medical visit. I want to highlight the success of Multnomah County Health Department in Portland, which linked 87% to care, Minnesota Department of Health that linked 94% to care, and the African Services Committee in New York City that linked 5% to care. In the next few slides, I'm going to point out some of the effective strategies that sites implemented in the programs. Next slide, please. Next slide, please. Some of the keys to success for Multnomah County in Oregon are listed on this slide. They noted successful outreach to healthcare clinics and community referrals. This was achieved through partnerships with local organizations. Developed hepatitis B voucher system for free testing to participants. Furthermore, to increase testing in hard-to-reach areas, they offered mobile testing in apartment complexes and refugee or immigrant organizations. The health department expanded refugee screening by adding hepatitis B screening to all refugees. They noted strong success to linkage to care was attributed to refugees taking advantage of 8 months of benefits through the state Medicaid program. Also, patient navigation with culturally competent staff was identified as a key strategy. Next slide, please. Keys to success for the Minnesota Department of Health program are listed here. They had a strong existing refugee health screening and viral hepatitis surveillance infrastructure, which they were able to leverage during this initiative. They partnered with experienced refugee clinics who serve people mostly from Myanmar and Somalia. They utilized 2 patient navigators whom were undergraduate students, one fluent in Somali and English, and the other fluent in Karen and English. And they were able to assist with hepatitis B education, scheduling appointments, and transportation logistics. Next slide, please. The African Services Committee in New York City primarily serves the African-born population. They noted strategic partnerships with various community-based organizations, including community centers, places of worship, employment sites, and African radio stations. These partnerships helped increase the number of African-born persons tested. Those who tested positive were linked to care at an academic health center or municipal health center depending on the insurance coverage of the participant. In addition, African Services leveraged multilingual professional patient navigators whose task was to make follow-up phone calls with results and appointments, transportation assistance, and escorts to medical appointments. Next slide, please. This slide summarizes successful implementation strategies in this initiative, and these included having an existing viral hepatitis surveillance program, partnerships with community organizations, health clinics, and departments of health, educational programs for providers and participants, the development of training protocols, and utilization of cultural and linguistically competent patient navigators. Next slide, please. There were limitations to our initiative and the evaluation. The medical visit data was self-reported. Many surface antigen persons noted pending medical appointments at the end of the project, and linkage to care indicators may have been underestimated. Participants may not be representative of all foreign-born persons in the United States. Lack of health insurance was noted as a barrier for subsequent follow-up visits. Also, no confirmatory surface antigen testing was performed 6 months after the first positive test. However, it is unlikely that participants who tested positive were newly acquired acute infections, as they were likely infected at birth or shortly after from their country of origin. Next slide, please. In conclusion, community-based efforts to screen hard-to-reach foreign-born people from hepatitis B virus endemic countries were effective in testing, counseling, and referring people with chronic infection to care. However, the referrals to care did not necessarily result in successfully attending a medical visit. We recommend the need to further develop strategies to increase linkage to hepatitis B directed care as a next step. Next slide, please. I'd like to thank my colleagues and co-investigators listed on this slide, and thank you for listening to me and your participation.
Well, thank you to our distinguished speakers, Dr. Ward and Dr. Harris. Those were great presentations. We'll now take questions. You may type your question for any of the authors into the chat or question box in the right-hand corner of the screen. Erin?
All right. Thank you, Dr. Shaw. It looks like we have a question for Dr. Harris. Health insurance status was noted as a barrier to care. How were you able to compare linkage to care among persons with and without health insurance? Dr. Harris?
Yeah. So about half of the persons with chronic hepatitis B reported having health insurance. And we did an analysis and found that there was no significant difference between surface antigen positive persons with health insurance status among those linked to care and not linked to care. However, half did not have health insurance overall, and this was identified as a barrier.
Okay, great. Next question. Dr. Ward, perhaps you can answer this. As a result of the CDC recommendations, how is HCV testing increasing in the country?
Well, HCV testing does appear to be increasing in the country. I outlined a number of strategies to promote testing, and it really comes down to capacity to make those interventions a routine part of care around the country. So our program is pretty modest when it comes to resources to make that happen. But despite those limitations, when we look at, particularly we've been monitoring commercial laboratory data from companies like Quest and LabCorp, we've got a clear increase of about 20 to 30% among people born in the birth cohort. So HCV testing does appear to be increasing. The CDC recommendation was also incorporated into the recommendations of the U.S. Preventive Services Task Force. And I think that additional level of recommendations really strengthened that overall message that this population was recommended for testing. and as many on the call may know, a USPSTF, a Category A or B, in this case it was Category B, intervention should be implemented without a copay of the patient, and so I think that appears to have spurred testing. And I know of some systems such as Kaiser Mid-Atlantic region where they have incorporated birth cohort testing for HCV as a routine practice, including performance measures for the physicians, etc. So I think as those types of practices become more widespread and more expected, we can see continued increases in testing.
Great, thank you. Dr. Harris, medical visit attendance may not represent hepatitis B directed care. How do you know if persons infected with hepatitis B received appropriate care?
So we were unable to assess the quality of care through this initiative. We did encourage the programs and sites to refer participants who tested positive to specialty care, but they were also referred to some primary care centers who had the capacity to manage patients with hepatitis B. We are currently working on future initiatives that is going to assess whether persons with chronic infection are receiving hepatitis B directed care, measured by whether they receive hepatitis B E antigen testing, ALT, and hepatitis B DNA measurements.
Great, thank you. Dr. Ward, I think this tags to the previous question on testing and the expense and coverage. I hear that the HCV drugs are expensive, complicating approvals of treatment for some patients. Is this a disincentive for HCV testing?
It might well be. We don't have a clear evidence of that. We have done some focus groups with physicians about their testing practices, and that issue of like I don't have the access to treatment, or the process of getting insurance companies to approve treatment has become very onerous. So we're concerned that that could be a disincentive, even though we don't have specific data that's looked at that question. We'd like to send a message that, first of all, there are other benefits of knowing one's status if they're hepatitis C infected, and not just curative treatment alone. You can begin to address other cofactors that accelerate the progression of hepatitis C, such as HIV or obesity or alcohol abuse, and work with the patient to reduce those risks. In regards to treatment, the treatment costs have probably declined about 50% since they came out about 2 years ago. So it looks like they're about $40,000 to $50,000 per curative course versus $84,000 to $96,000 several years ago. As a result, the Medicaid programs and others, as I mentioned earlier, are beginning to lessen restrictions which were really onerous for patients. I mean, only approving therapy for those that already had cirrhosis was really very restrictive. And then having evidence of the patient not having a problem with alcohol or substance abuse, added on additional burden, and then over on top of all of that, requiring a specialist such as a liver specialist or infectious disease physician to order the drugs. So all of that taken together was a really restrictive set of policies that fortunately are beginning to improve. And so hopefully over time treatment access will be broadened, and it will be viewed as an additional incentive to test rather than being a complicated process that can serve as a deterrent to testing.
Great, thank you. Dr. Harris, what proportion of the population tested was immune to Hep B? Was surface antibody measured at all?
Unfortunately, we didn't measure the hepatitis B surface antibody in this initiative. We did ask participants whether they had received any hepatitis immunization, and that could have been hepatitis A or B vaccination. 37% reported receipt of a hepatitis vaccination. 23% of the surface antigen positive persons reported receipt of hepatitis immunization. So what this really shows is self-report of vaccination status is not reliable, and we encourage surface antibody and core antibody testing to be included when screening an individual for hepatitis B so that we can properly classify them as being immune, having past infection, current infection, or being susceptible and would benefit from the hepatitis B vaccine.
Great. Perhaps you can follow up on this one, Dr. Harris. Was vaccination offered to those that tested negative, irrespective of age?
That is a good question. In this initiative, hepatitis B vaccine was not included as a requirement for the programs. We did encourage programs to offer or refer to vaccine services if they were able to. And currently, in the current initiative where we are looking at hepatitis B directed care, we do have some supplemental funding to support hepatitis B vaccine in individuals who are identified as being susceptible.
Great, thank you. Dr. Ward, how often should one screen an injection drug user or others at ongoing risk for becoming infected?
Probably about an annual basis appears to be the most reasonable criteria. If someone's exposed to the virus for the first time, it usually takes about 6 months to know for certain whether that person has cleared the virus on their own, known as spontaneous clearance, which happens, as I mentioned, about a third of the time, or they're going to become chronically infected. It used to be in the interferon era of the past, it was very important to find people early because interferon-based treatments were more effective for the acute infection rather than those who became chronic. There hasn't been a lot of studies yet using the new drugs for acute infection, but they're so effective for chronic infection, there's not quite the importance for that individual's success at clearing virus with treatment. So the main, so I think increasing in importance has been identifying a new infection early so that you can identify a transmission network more quickly and then seek to intervene to stop transmission within the community. It can also help you identify reinfection after someone's been cleared. A person can become reinfected after viral clearance, either spontaneously or because of treatment. And so again, it will help you identify new transmissions within the community, and hopefully you have the capacity at the public health level to investigate and intervene to stop transmission. So, if you could, people with active ongoing risk, annual testing is recommended.
Great, thank you. Dr. Ward, this refers back to the preliminary results that you discussed from the project focused on testing and linkage to care among PWID showed high rates of linkage to care in Wisconsin and Louisiana. What strategies did they employ to link patients to care? Can you comment on that?
I don't have the information specifically about those two sites. I think in general, the sites that were most successful had been doing testing already, and they had some established procedures that were enhanced by these additional resources versus other sites that were doing this for the first time. But that's what I can say about all of the sites taken together. I don't have specific information about those two sites.
Okay, great. Here's a question for either of you, if you can comment. There was a draft case definition for HCV perinatal cases. Has that been finalized? And if not, do you know the status?
So we, CDC works with the Council of State and Territorial Epidemiologists to develop case definitions for reportable conditions. The topic of having a case definition for perinatal HCV was discussed at the annual meeting of CSTE this past June. A decision was made that more evidence was needed to support a recommendation for national reporting. Since that time, we have put out, as well as at least one other institution has put out more information around perinatal HCV, and I think there's a lot more recognition of the importance of this problem. And so we expect that case definition will be approved at the next CSTE meeting in June of 2017. I think that will be very helpful to standardized reporting. I know in Kentucky, the state I highlighted in the slide, they're probably furthest out in taking action around this mode of transmission. They have passed a law requiring birth attendants, obstetricians, etc., to report positive tests for HCV among pregnant women, so they have a reporting law, and they're beginning to publish regular results, on the results of that testing, on that testing law. But we know that other states have this problem, and we know that surveillance case definitions will greatly help create a uniform reporting structure so we can strive for comparability of data across states. And so that's one of our first orders of business in the coming months is to make sure that happens while we also are beginning to see what are the right testing recommendations for the country for HCV-infected women.
Great, thank you. This is another general open question. What type of staff conducted the linkage to medical care activities? Was it peer navigators or community health workers, patient navigators? Can you elaborate on the linkage?
Well, I mean, I'm sure, Aaron, I think, highlighted some of this. I think it varied. In some clinical settings, it tended to be medical personnel, such as nursing staff, but it also included, peer navigators, in other settings. That degree of sort of human interaction may vary. They may have just gotten a letter and a set of instructions, or there could have been a phone call and said, you have an appointment on this date, and and make it. So I think that there was some variability in that regard, at least in the HCB studies. Aaron, you want to comment further on the hepatitis B studies?
Yeah, sure. So it was similar for the hepatitis B studies. Each program was required to systematically collect their metrics on the linkage to care, so that's how we had all that nice data in the care cascade. But then each site was very different on the process for which they were achieving each of those metrics. And what I pointed out were some of the programs that were most effective, and what seemed to be most effective was actually having a patient or peer navigator to, especially for the foreign-born population, to help navigate them through a very complicated healthcare system, even with things such as helping with making appointments and following up with the appointments, following up with results, and just being able to communicate those messages to the participants. Other programs that were maybe less successful in terms of achieving the attendance of the medical visit, maybe had less emphasis on the patient navigator and we're more relying on phone calls or letters or more of a passive approach. The more active approach with a patient navigator is more costly and requires more resources, and that also seemed to be most effective. So I think we are currently doing a number of cost-effectiveness analyses to see which of these different strategies might have the biggest bang for the buck to make sure that we optimize linkage to care for the foreign-born community.
Great, thank you. There's a prevalence of some organizations and clinics giving vaccination prior to HBV testing. Do either of you have a view of this process and procedures?
I'm sorry, I missed the first part. What did you say at the beginning?
Oh, okay. Many organizations and clinics give the vaccination prior to even doing the HBV test. Do you have an opinion of this process?
Well, Dr. Ward, I'll let you speak in a second, but I think it makes most sense to do the testing first because, and I think it's important to do the testing with surface antigen, surface antibody, and core antibody so that you can appropriately classify the patient as being immune, having past infection, or being susceptible. Because I think vaccinating people who are already immune or have evidence of past infection is not a good use of our precious resources.
Right. So the yes, I mean I think that's I agree in different respects what Aaron highlighted. Our hepatitis B testing recommendations that CDC published in 2008 for populations at risk for hepatitis B infection, they recommend that the testing and the first dose of vaccination happen at the same visit so that you don't miss that opportunity of beginning to afford some protection to a high-risk individual such as a person who injects drugs or a man who has sex with other men. It's also recommended, again, to Aaron's point, that if you feel like there's a high proportion of the population that you're seeing in your clinical setting that already has had previous exposures, then for cost considerations you may want to test, and then decide to vaccinate based on that testing result. And that varies by what's your cut point there. It does vary. I know in the current guidelines, which were developed around 2006, it was around if your prevalence of previous exposures, that's antibody positive or core antibody positive, was 30% or more, it made economic sense to test and then vaccinate. So there's a little bit of vary there, but there's the vaccine, if you've been previously exposed, if you're surface antigen positive, the vaccine's safe. It's not going to cause you any trouble if you go ahead and get vaccinated. There's no contraindication to that. So, ideally, if your outcome goal is to assure protection and you're worried about the continuity of care and that person returning, then even one dose of vaccine is better than no doses. You get about a 50% protection from one dose. So, so it varies a little bit. It has to be tailored to the clinical setting. Strictly speaking, we recommend that the vaccination and the testing happen at the same time, but recognizing that has to be tailored to the clinical circumstances.
Wonderful. Thank you so much. That was a very very informative Q&A session, and I'm afraid that's all we have time for. Next slide, please, and I'll turn it back over to Dr. Shaw.
Thank you, Erin. I want to thank everyone who attended today for joining us, and a special thank you to the speakers for their great presentations and to their staff for their time and contributions and assistance for this very important public health topic. I also want to thank Erin Williams for managing this webcast for the Association of Schools and Programs of Public Health, and of course to the Office of the Surgeon General for its continued support of the journal. A quick reminder that anyone seeking 1 credit for certification in public health continuing education practice, you will need a password for the credit. The password for this webinar is PROGRESS, P-R-O-G-R-E-S-S, progress. The next slide, please. Well, this is the end of the Public Health Reports Meet the Author webinar. As a reminder, this webinar will be archived on the ASPPH website for future viewing. Thank you, everyone, and have a good day.